Welcome back, pathology professionals. When people think about laboratory testing, they think about the analyzer. They picture a sample going onto a machine, the machine running a test, and a result appearing on the screen. But laboratory medicine is much bigger than that. The analyzer is a critical part of the process, but it is only one component within a much larger diagnostic system. Before a result is produced, the right test must be requested, the right patient must be identified, the right sample must be collected, labeled, packaged, transported, received, prepared, and analyzed. And after analysis, the result needs to be reviewed, authorized, reported, communicated, interpreted, and used to guide patient care. This entire pathway is known as the total testing process. In this three-part series, we are going to break down what the total testing process really means, where errors commonly occur, and why understanding this concept is critical for laboratory quality and patient safety. The total testing process is the complete pathway of a result. It begins before the sample even reaches the laboratory. At the moment a clinician recognizes a clinical question and decides that a laboratory test may help answer it. From there, the process continues through the test requesting, patient preparation and identification, sample labeling, sample collection, packaging, transport, sample reception and processing, analysis, result review, reporting, interpretation, and finally, a clinical action. So the total testing process is not just about what happens inside the laboratory. It is the full journey from a clinical question to a patient sample to a result and finally the decision that supports patient care. So let's walk through that journey step by step. A patient presents with signs and symptoms. The clinician assesses the patient and formulates a clinical question. At this point, the clinician needs to understand what they are actually trying to find out. Are they trying to confirm a diagnosis, exclude a condition, monitor disease progression, assess treatment response, or investigate an abnormal clinical finding? That clinical question should guide which laboratory test is requested. This is important because not all tests that seem related answer the same question. For example, if a clinician wants to know a patient's blood glucose level, then a glucose test may be appropriate. But if the clinician wants to understand the patient's average blood glucose control over the past few months, then an HbA1c may be more appropriate. Both tests are related to glucose metabolism, but they answer different clinical questions. So, appropriate test selection matters. The wrong test may still produce a technically correct result, but it may not answer the clinical question. And if the test does not answer the clinical question, it can delay diagnosis, create confusion, lead to repeat testing, or affect patient care. The clinician then orders the appropriate laboratory investigation, either electronically or on a manual request form. This request should include correct patient details, the tests required, the requesting clinician, and any relevant clinical information needed to help the laboratory process, prioritize, and interpret the request correctly. This decision to request a test is the first step in the total testing process because before a specimen is collected, transported, analyzed, or reported, someone must first ask the question that the laboratory result is intended to answer. The patient then attends a collection center. Identification is confirmed using a unique patient identifier, such as an identification document or hospital number. The phlebotomist then labels the required specimen containers and uses the correct procedure to collect blood specimens from the patient. The specimens are then prepared for transport. They must be packaged and transported to the laboratory in a way that protects both sample integrity and safety of everyone handling the sample. The phlebotomist preparing the specimen for transport must ensure that the samples are correctly sealed, packaged, labeled, and stored according to the test requirements. The courier must then transport the samples according to the agreed procedure, maintaining the required conditions as far as possible. This is important because poor collection, packaging, and incorrect transport conditions can compromise the sample before it even reaches the analyzer. A delayed, leaking, overheated, frozen, or incorrectly stored sample may produce inaccurate results or may not be suitable for testing at all. It can also create health and safety risks for couriers, laboratory staff, and anyone else who comes into contact with the specimen. The samples are then received by laboratory administration staff or laboratory assistants at specimen reception. Before the samples are logged into the laboratory information system, staff must check that they are safe to handle. This includes looking for obvious health and safety risks. They check whether the samples appear to have been transported in a suitable manner. For example, they may assess whether the specimens arrive in the correct transport container, whether the packaging is intact, whether the sample was protected from leakage or breakage, and whether any required temperature conditions appear to have been maintained. Once it has been confirmed that the samples are, are safe to handle, the next step is to confirm the identity of the patient and match the specimen to the request form or electronic request. This is done by checking approved patient identifiers, such as patient's full name or surname, date of birth, NHI number, hospital number, or laboratory information or referral number, depending on local policy. The details of the specimen label must match the details of the request form. If the sample is unlabeled, mislabeled, illegible, or does not match the request form, it creates a serious risk of reporting results on the wrong patient. These types of errors must be managed according to the laboratory's sample acceptance and rejection procedure. Reception staff then check the tests that have been requested and compare them with the samples received. They need to make sure that the correct tube or container has been used for the requested test. For example, a full blood count requires an EDTA tube. Coagulation testing requires a correctly full citrate tube. They also check whether there is enough sample to perform the requested tests. If the volume is too low, the sample may not be suitable, or there may not be enough specimen to complete all the requested tests. In some areas, such as coagulation, the full volume is especially important because an incorrect blood to anticoagulant ratio can affect the result. The sample is then visually inspected for suitability. Staff may check whether the sample is clotted when it should not be, hemolyzed, or otherwise unsuitable for testing. They also check the date and time of collection to make sure that the sample is still within the acceptable stability period for the test requested. Some tests have special requirements, and these must be identified at reception. A sample may need urgent processing, protection from light, transport on ice, immediate centrifugation, or specific timing or documentation on fasting status. If these requirements have not been met, the result may be affected, and the sample may need to be queried, rejected, or referred to a senior laboratory staff for a decision. This step is a critical part of the pre-analytical phase, and the goal is not just to log the sample quickly, but to make sure that the right sample from the right patient has arrived in the right condition, in the right container, within the right time frame for safe and accurate testing. Once a sample has been accepted and registered into the laboratory information system, they are then prepared and distributed to the relevant departments for testing. This step is often called specimen processing or pre-analytical processing, and it is a critical part of the laboratory workflow. The aim is to make sure that each sample is prepared correctly for the test that has been requested, while maintaining sample integrity and patient traceability. Depending on the type of specimen and the test ordered, sample preparation may include steps such as centrifugation, separation of serum or plasma from cells, aliquoting into a secondary tube, temporary storage, refrigeration, freezing, or holding samples for batch testing. For example, some blood samples may need to be centrifuged before testing so that the serum or plasma can be separated from the cellular components of the blood. Other specimens may need to be aliquoted, which means transferring part of the sample into another labeled container, which is often done when the sample needs to be shared between departments, sent to another lab, or stored for later testing, or protected from repeated handling of the original tube. Every aliquot must be labeled and traceable back to the original patient, original specimen, and original request. This is important because once a sample is separated or divided, the laboratory still needs to know exactly who it belongs to, what specimen type it is, when it was collected, and what tests are required. Some specimens may need to be stored before testing. This could include keeping the sample at room temperature, refrigerated, frozen, protected from light, or brought to room temperature before analysis, depending on the test requirements. These conditions must follow the laboratory standard operating procedure, the test method, and the manufacturer's instruction where applicable. Samples should only be stored for batch testing if the test allows it and if the specimen remains stable under the required storage conditions. If the sample is stored incorrectly or for too long, the result may no longer be accurately reflecting the patient's condition at the time of collection. After processing, the samples are distributed to the appropriate departments, such as hematology, chemistry, coagulation, microbiology, immunology, transfusion science, or a referring testing lab. This distribution needs to be controlled so that the samples reach the correct area within the required time frame and in the correct condition for testing. In many laboratories, this work is performed by laboratory assistants, technicians, or scientists, depending on the type of laboratory and the complexity of the processing required. Routine tasks may be performed by trained laboratory assistants, while more complex processing, unusual specimens, or problem samples may need to be escalated to senior technical staff or scientific staff. Once a sample is logged into the system, the work does not simply move straight into testing. The samples must first be prepared correctly, labeled correctly, stored correctly if needed, and sent to the correct department. This ensures that the sample remains suitable for analysis and that the result produced by the laboratory is reliable, traceable, and safe to report. Within the laboratory, specimens are analyzed using methods that have been validated or verified for their intended use. This may involve automated analyzers, semi automated systems, point of care platforms, microscopy, culture based methods, or manual techniques, depending on the department and the test requested. Before patient results can be reported, the laboratory must make sure that the testing process is under control. This means checking that the correct method was used, that the analyzer or test system was functioning correctly, that the reagents and consumables were suitable for use, and, and that the required quality control results were acceptable. For automated testing, the analyzer may generate results directly into middleware or the laboratory information system. However, those results still need to go through a review process before they are released. This review may include checking the analyzer flags, abnormal results, critical values, sample quality indicators, dilution requirements, delta checks, reference intervals, and whether the result makes sense in relation to the test requested. For manual techniques, the same principle applies. The result must be produced by a trained and competent staff using the approved procedure with appropriate controls and documentation. Manual testing often requires careful interpretation, so these results may need additional technical or scientific review before authorization. Some samples are reviewed manually by authorized laboratory staff. In other cases, results may be released through auto verification, where the laboratory information system or middleware automatically releases results that meet approved safety and quality rules. This can only happen if the rules have been properly set up, tested, approved, and monitored by the laboratory. If the result is unusual, unexpected, outside critical limits, affected by sample quality, or does not meet the laboratory's release criteria, it should not be released automatically. It must be held for review, repeated if necessary, investigated, or escalated to senior staff according to laboratory procedure. Once the result has been reviewed and authorized, it is released through the laboratory information system as an official laboratory report. The report is then made available to the requesting clinician or the healthcare provider. The World Health Organization guidance states that laboratory results should be reported in a final, authorized report to the requester using accepted terminology, reference intervals, and appropriate reporting procedures. For urgent critical results, release through the computer system may not be enough. These results may also need immediate communication to the requesting clinician or clinical team. Following the laboratory's clinical critical results notification procedure. This ensures that clinically significant results are seen and acted upon as quickly as possible. So, specimen analysis is not just about producing a number or a positive or negative result. It is about using the correct method, confirming that the testing system is performing properly, reviewing the result appropriately, and only releasing results that are reliable, traceable, and safe for clinical decision making. Finally, once the result has been released, the clinician interprets it in the context of the patient's clinical picture. A laboratory result should never be reviewed in isolation. It needs to be considered with the patient's symptoms, history, examination findings, medication history, previous results, and any other relevant investigations. The same result may have different clinical significance depending on the patient and the reason the test was requested. The clinician then uses that information to make a medical decision. This may include confirming a diagnosis, ruling out a condition, monitoring disease progression, adjusting treatment, requesting further tests, referring the patient, or taking urgent action if the result is critical. So, while the laboratory's role is to produce and report reliable results, the purpose of the testing pathway is only fulfilled when the result is interpreted correctly and used to guide patient care. This is why we divide the laboratory testing pathway into three major phases: the pre-analytical phase, the analytical phase, and the post-analytical phase. The pre-analytical phase includes everything that happens before the sample is analyzed. It includes the test request, patient preparation, specimen collection, labeling and packaging, transport, sample reception, acceptance checks, and sample preparation. The analytical phase is the testing phase. This is where the specimen is examined using an approved method, whether it is an automated analyzer, a manual technique, microscopy and culture, molecular testing, or another laboratory method. The post analytical phase includes whatever happens after analysis. This includes result review, interpretation where required, authorization, reporting, communication of urgent and critical results, and making the result available to the requesting clinician. The post analytical phase is recognized as the stage where results are evaluated, released, and communicated for clinical use. Each phase depends on the others. A perfectly functioning analyzer cannot correct a mislabeled sample. A well collected sample cannot compensate for poor quality control during analysis. And an accurate result is of limited value if it is delayed, sent to the wrong person, misunderstood, or not acted on appropriately. That is why quality in laboratory medicine is not just about the analyzer, it is about the entire testing pathway. From the moment the test is requested to the moment the result supports patient care. The idea of the total testing process is closely linked to the work of American pathologist George D. Lundberg, who introduced the concept as known as the brain to brain loop. He recognized that laboratory testing is not just a technical procedure that begins and ends with the analyzer. It is part of a much larger diagnostic cycle. That cycle begins in the clinician's brain when they recognize a clinical problem and decide which laboratory test may help answer their question. It then continues through patient preparation, sample collection, labeling, transport, sample reception, specimen processing, analysis, result review, reporting, interpretation, and finally clinical action. In other words, the laboratory result is not just a number produced by a machine. It is the outcome of a connected pathway involving the patient, the clinician, the phlebotomist, the courier, the laboratory team, the analyzer, the laboratory information system, and the healthcare provider receiving the result. The analyzer is only one component within that loop. And while the analytical phase is extremely important, it is often the steps before and after analysis that create the greatest risk to patient safety. A result can be analytically perfect, but still clinically unsafe if the wrong test was requested, the wrong patient was identified, the sample was collected incorrectly, the specimen was delayed in transport, the result was reported to the wrong place, or a critical result was not acted on. The brain to brain loop is a conceptual model. It is not an ISO clause, and it is not a single accreditation requirement that laboratories are audited against word for word. However, modern laboratory quality standards are built around the same principle, protecting the integrity of the entire testing pathway. This is why standards such as ISO 15189 focus not only on the examination or analytical phase, but also on the pre analytical and post analytical processes. The goal is to reduce risk at every stage where an error could affect the patient. So, when we talk about quality in laboratory medicine, we are not only talking about the analyzer precision, quality control, and calibration. We are talking about the entire journey of the test. Evidence from laboratory medicine consistently shows that errors are not distributed equally across the testing pathway. The majority of errors occur in the pre analytical phase, the stage before the sample is analyzed. Many studies report that the pre analytical phase accounts for around 60 to 70% of laboratory errors, although the exact figure can vary depending on the laboratory setting, the department, and how errors are measured. The analytical phase, which is the actual testing phase, usually accounts for a much smaller proportion of errors, often around 5 to 15%. This does not mean that the analytical phase is unimportant. It remains critical, but modern analyzers, automation, internal quality control, external quality assessment, calibration, maintenance, and method verification have made this phase more controlled than it was historically. The post-analytical phase accounts for the remaining errors, often reported around 15 to 25%. This is important because it challenges a common assumption. When people think about laboratory errors, they often imagine the analyzer giving a wrong result. But in reality, the analyzer is not usually the predominant source of error in medical laboratories. Most failures occur outside the machines. The total testing process is not just the journey of a specimen, it is the protection of a clinical decision. Excellence in laboratory medicine is not defined only by analytical precision, but by how well the entire examination process is designed, controlled, and monitored. In part two, we'll go deeper into the operational controls within the pre analytical phase and examine where high risk failures occur. Thank you for watching, pathology professionals. If you found this helpful, make sure you like and subscribe, and stay tuned for the next part in this series.